Welcome to the latest episode of CarePoints. I'm your host, Kenny Schiff, Director of Marketing for Lone Star Communications' new subsidiary, Alero Solutions. Today's episode is part of my continuing series of conversations with my collaborators at Lone Star and Alero, customers, partners, notable folks in the healthcare and tech industry. It is my pleasure to interview the pioneering healthcare technologists, John Elms and Brian McAlpine. John Elms is an accomplished executive with over 25 years of leadership experience in the high-tech industry. His career spans various roles, including CEO positions at public and privately held companies, venture-backed startups, and his own entrepreneurial ventures. I'm also proud to have Brian with us today. Brian McAlpine has spent most of his 30-year career assisting innovative startups with developing and taking to market solutions focused on the provider side, primarily in acute care. Welcome, John and Brian. Today, we're going to focus on the role of middleware and CC&C, or clinical communication collaboration, in the hospital enterprise in the EMR/EHR era. Both of our guests were pioneering participants in the development and marketing of what many of us know as alarm middleware. In the early days, it was about creating a bridge between systems like nurse call and telemetry, and providing a method to send alarms and alerts to pagers and early generations of proprietary in-building wireless phones. In recent years, the shift has been towards clinical workflow enabled by smartphones from Apple and various Android-based devices from the likes of Zebra, SpectraLink, and Ascom. John, you're in a unique position to have been part of the evolution of connected devices and workflows, starting with your executive role at SpectraLink and continuing with your time at Connexall, Critical Alert, and Tiger. Between you, me, and Brian, we've been around this stuff a long time, going back 10, 12 years ago. We all were very excited about the possibilities of middleware, smart alarms, and universal connectivity. Did it turn out the way we imagined? What happened along the way?
It did not turn out as we had imagined when we started. Back in 2010, when I formed Connexall USA with my colleagues in Canada at Globestar Systems and the folks that we brought on, we envisioned an ecosystem with, I suppose we would call it an automated air traffic control system, one that would manage the delivery and prioritization of medical device alerts and alarms, making sure they got to the right person on the right device at the right time. It didn't go to the wrong person on the wrong device. As a reminder, this industry began with the introduction of wireless telephones into the healthcare enterprise. And that's where I entered back during my tenure at SpectraLink. And at that time, wireless telephones were replacing pagers that nurses carried, in-building wireless pagers that nurses were carrying to alert them of a nurse call event. Once we brought phones in, the intent then was to connect those phones to the nurse call systems and replace the pages. Over time, we added more connected devices and information systems and improved routing and escalation. At the beginning, it was simply a pager number, if you will, that was connected to a paging port in the nurse call system. And over time, the sophistication and the complexity increased. But that said, it's still almost all about nurse call. That physiological monitors and electronic medical records and notifications from those EMRs like stat orders and critical labs, they've all been added to the ecosystem that we talked about at the beginning. But the fact of the matter is, when you look at the numbers of connections in a healthcare system connected to a mobile communication platform, it's still predominantly about nurse call. So in spite of the Joint Commission mandate of 10 years ago, where they said to the hospitals for which they provide accreditation, you must get your arms around these medical device alarms and alerts. Patients are being harmed. It is a top 10 driver of preventable medical errors in healthcare, rated in the top 10 by ECRI and others for many, many years running. But yet it's still a problem. And the reason, in my estimation, that we haven't made more progress since 2010, when I got involved, is the manufacturers themselves don't want to cede control of the workflow, the routing, the escalation, the notification, the control, if you will. So medical devices are smarter and smarter with each successive generation and turn of the crank, if you will. But the fact of the matter is those smart devices and the manufacturers of those smart devices stand alone often and don't cede control to that air traffic controller that we envisioned back in 2010 and before.
And the customer is somewhat caught in the crossfire between the manufacturer and their specific needs. And all of us have had to live through that. What needs to be different for that kind of situation to go away, where the customer has specific integration needs, and yet the manufacturers don't seem to want to cooperate with each other?
I think it would be fair to say, and we see this with Epic on the EMR side, the customer is king. When the customer demands a certain capability or feature, by and large, those manufacturers will respond to the customer. But when a manufacturer or a provider of a software application wishes to enhance their application, there's often a lot of contention between competing priorities. So at the end of the day, it's got to be about the customer, and the customer needs to be loud. They need to be demanding.
Yeah, and I think a lot of our mission kind of collectively is to educate the customer so that they can be smarter about what they ask for. Let's turn the conversation to Brian. Brian, in some recent conversations, you brought up the idea that many institutions end up with the accidental architecture. Can you explain that a bit? And then when you're done, has anybody gotten this right? And if so, what have they done to get it right?
Sure. The accidental architecture is really, it's a concept that goes back many years. It doesn't necessarily apply strictly to, to healthcare. I mean, it applies in general, but in general, and accidental architecture is how healthcare organizations end up with essentially an unmanageable mess of integrated systems, to put it that way. If we go back, say, 15 or 20 years, when many hospitals started with a simple integration to nurse call, sending those types of alerts to pagers. As technology advanced, though, the requirements to connect and integrate more things also increased. Most organizations didn't have a vision for what the end state would be, so they simply charged ahead, adding more integrations to support more of the workflows. Different vendors would offer piecemeal solutions, but those often did not fit seamlessly into the existing environment, which added complexity to the overall mix. So eventually, many organizations, what happens is they wake up one day and realize they've accidentally created a complex infrastructure that they never originally intended, which of course is the accidental architecture. And I can give you some examples of the end result of how these accidental architectures evolve into this kind of mess of integrated systems and the impact of that. One is that it causes clinicians to have to carry multiple devices like pagers, phones, and multiple devices to communicate and receive the events and alarms. That's because different vendors provide different ways to receive the alarms, and not everything works seamlessly when you're building the accidental architecture. The other result is there's no prioritization or control over how often the clinicians are notified, or to ensure that only actionable alarms are received. And another impact is that staff assignments end up having to be managed in multiple applications, which of course is very time consuming and redundant in many different types of deployments. So all of this is in contrast. It contrasts with a comprehensive design and planning process that had organizations had the foresight way back then, could have planned for a future state, but they didn't necessarily know what the future state would be. So they ended up in the situation they're in. CC&C vendors can help clean up accidental architecture because they provide a platform to help control and manage the alarms. So many organizations see this as a broader problem that extends beyond just clinical communications. So as a result, many see the EHR as that central platform that can be used to reduce complexity and costs, of course. And in the process, they can also eliminate some of the vendors. I think this is one of the real threats facing the standalone CC&C vendors. And finally, I think some organizations have got this right. Those that did mainly have focused on implementing a full CC&C solution that's closely integrated with the EHR, but those represent a relatively small percentage of the market. Even today, most hospitals have multiple vendors for managing various types of messaging and for managing alarms. So it really is a mix of where healthcare organizations have ended up as a result of this accidental architecture.
And it's really hard to untangle the accidental architecture. So a few things end up happening. One is the organization becomes completely reliant on a particular workflow. Re-engineering that workflow is too hard. And then similarly, people who may have been involved when the original solution was concocted are gone. So the institution is missing key knowledge. And then there's less people in the healthcare enterprise, especially from an IT perspective, to do all this. So it's really hard to take a step back and say, okay, let's do this over. Brian, let's have you a follow-up on that. Is there a place for Epic-centric alarm and alert presentations with CC&C and middleware still in the mix?
Yeah, that's a great question. And I think there is. Today, it's really a multi-vendor environment. Customers are asking for these Epic-centric workflows. They're looking to leverage Epic's mobile applications wherever they can. They've spent a lot of money on Epic and they want to leverage what they've purchased. Epic has the ability to present and manage alarms inside their Epic Rover mobile app. So nurses can get various types of these alerts and alarms on their mobile devices and manage it within Epic. And many of the CC&C vendors provide a validated alarm management integration into mobile apps such as Epic Rover that's primarily used by nursing. The standalone alert and alarm management vendors like ConnectAll, they also have validated live integrations with Epic. And when it comes to managing alerts and alarms, the EHR vendors like Epic make a big distinction between alerts like, say, example, a critical lab result and life-critical alarms. There's a big distinction between the two. Life-critical medical alarms come from medical devices. And because of the regulatory concerns, Epic has not integrated directly with devices like patient monitors to manage alarms. So this actually supports the market for standalone alarm management platforms because customers often want a unified way to manage all of the alerts and alarms. It's like in a single platform. However, sometimes all that's required, you don't need a comprehensive platform. Sometimes all that's required is a basic integration to nurse call. So every customer has a different starting point and a different set of requirements. So there's clearly a place for CC&C, Alarm Middleware, and Epic to all work together. And there are many instances of that deployed in the market.
And going back to what John said, that if the customer takes charge of its own future and articulates its needs, then the various players who are involved in architecting the solution have to comply to the requirements that the organization is putting in front of them. So
yeah, it all comes down to those requirements.
So John, let's go to you. So we brought up CC&C a bit, and we've sort of converged CC&C and middleware, and what we used to think of as middleware is now CC&C. So can you give me your perspective on where the CC&C market is headed from your point of view?
Yeah, sure. And I suppose at this point I've become the agent of doom in some respects because, as Brian mentioned, what prevents Epic from entering the middleware market is not technology, it's regulatory and its desire not to be FDA regulated as a Class 2 medical device. The day that that changes, the landscape will change. And history would tell us that the long-term prognosis is not very good for standalone application providers for CC&C and middleware. I've been involved in an awful lot of technologies over my, now I suppose, long career, and good enough features always supplant best of breed applications when they're tightly integrated with an enterprise platform. So for me, I was very early in video conferencing. We're going back to the very early 1990s now, when PictureTel established enterprise video conferencing, largely for the Fortune 500s at the time. But at that point in time, it was the first video conferencing system that was able to be deployed in a conference room and could use the wide area digital telephony infrastructure for video conferencing. Fast forward 30 years, and now we all have video conferencing. We're on a video conference now. On the commercial side, WebEx, Teams, Zoom, they are ubiquitous, particularly post-COVID. On the consumer side, we have FaceTime and Facebook messaging and WhatsApp messaging and Skype and on and on and on. So in 30 years, what was a really interesting technology and technological advancement has just been rendered as, so what? Everybody's got video today. So I see this, or I have seen this also in healthcare, right? When I started at Connexol, PISIS and T systems were two very dominant applications in the OR and the ED, respectively. Today, those features have been subsumed by the EHR. We don't hear so much about PISIS and T systems any longer. Recently, we've seen it in telehealth, right? Optum recently has declared that they're leaving the market. We look at Teladoc and Amwell, and their shares are trading at 52-week, in fact, 5-year lows. That telehealth is undergoing a major change, and one would presume that if the telehealth is not embedded in the electronic health system, the EHR, if you will, that a standalone video conferencing or telehealth extension to video conferencing will not thrive on its own. So for those reasons, it's really hard for me to make a case that CC&C and middleware will thrive as standalone applications in the face of competition from the EHRs. Think back when we were all, in my case, less bald, your case, less gray, when we had web browsers that were not part of the Microsoft suite. Those web browsers may be interesting, like Opera and whatever else, DuckDuckGo, but the fact of the matter is Safari, Edge, Chrome, they dominate, and the standalone market like we had for Netscape don't exist anymore. I think it's inexorable, and that's why I would say CC&C and middleware will be challenged. I can't say that it's this year or next year, but history tells us there are challenges ahead.
So in our kind of prep, you mentioned building automation systems, access control, temperature, those kinds of things. Is that a place that the people who are providing some of those services could be focusing more of their attention? Are you saying that the doom and gloom you're speaking of is comprehensive, or does it really have more to do with clinical workflow applications?
So that's a topic in my answer to one of your future questions, Kenny. But the fact of the matter is there is a case to be made that there are gaps that need to be filled between what is currently available and what is likely to be available in the, I'll say, midterm, near to midterm. Let's call it the midterm. And as you said, building automation systems will be fundamental to that. Integration with access control, lighting, temperature, uh, sanitation, med gas, all sorts of other things that are particular to the healthcare enterprise, but may not be particular to the EHR and the focus of those applications. So, yes, a broader set of integrations, but the idea that we're going to exist on physiological monitors and nurse call for the long term, that's not likely to be the case in my mind.
Yeah, and some of the sort of ancillary augmentative technologies that, from a building standpoint, et cetera, those don't. There's no real place for them in Rover, or probably not foreseeable, right? So there to be one single application that rules them all, that's probably not happening.
That doesn't necessarily have to be the case, right? Uh, Hospital transporters and phlebotomists and environmental services staff, if the price point was set, I dare say right, but let's just say at a level at which the healthcare enterprise decided to license that community of staff, then there's no reason why Rover couldn't be able to communicate patient transport requests and phlebotomy requests and environmental services requests.
Right, but as we discussed earlier, the organization has to have a vision of that, and they're going to have to figure out a way to get there. So I find that people are pretty aspirational and not realistic about what it's going to take for them to get where they want to go. Brian, let me turn to you. We've talked about patient engagement as a related set of technologies. How does it or does it not intersect with CC&C and nurse call?
There's already a lot of overlap in some of these markets and some of these products. And patient engagement, so to kind of define it a little bit and to create a working definition, it's very different in the hospital, the way it's been used compared to the broader adoption across, say, a healthcare enterprise. So inside the hospital, there are product categories such as interactive patient care. So interactive patient care refers to a collaborative approach where patients actively participate in their own care journey. And it involves using technology and communication tools to engage patients during their hospital stay and beyond in many cases. Outside the hospital, it's different and across the enterprise. Patient engagement is more about empowering patients through education, and engagement improves decision making and adherence to things like care plans. It also enhances both caregiver and provider communication and data sharing, and that leads to better patient management. So if you apply that as kind of my working definition of what patient engagement is and how it's a little bit different inside the hospital as versus across the enterprise, it starts to become a little more clear, at least to me, that fundamentally this boils down to a situation where communications need to be improved, whether you're inside or outside the hospital. So I mentioned this overlap among nurse call, interactive patient care, as well as there's an overlap among the CC&C and patient engagement, if you look at those as market segments. Some of the prominent industry analysts have advocated for many years now that there'll be a day when a combination of CC&C and interactive patient care can essentially replace the functionality provided by a traditional nurse call system. And I for one, agree that and think that that is definitely possible. And looking at the CC&C vendors, one area that they expanded to in, say, the last 5 years or so is with clinician to patient communication. Up to that point, the CC&C vendors' messaging was strictly designed to be between members of the care team and hospital employees. But healthcare organizations know they need to change and adapt in order to survive. And it's recognized that patient engagement will play a role in that. And further, so you look at what Epic's been doing, they've been developing solutions in this area for patient engagement. And that supplements what they're doing with their the Epic MyChart portal that's seeing more adoption, especially with the onset of the pandemic and post-pandemic. Then they have Epic Cheers, which is Epic's patient engagement branding for what they're doing in that area. And then they have Epic Hello World, which is their solution for patient messaging. And Epic's clearly going after these markets. So given all of this and the influence of Epic, I see how, easily see how it's ultimately how the market will converge and how this becomes really a major risk to the standalone CC&C vendors. When I look to the future, I see, and John talked about this a little bit, but I see a single comprehensive platform that combines messaging, patient engagement, and really all forms of communications. And I would include contact centers in that mix. And, one thing's pretty sure is that, going back to that whole concept of accidental architecture, healthcare organizations are looking to clean that up. They're looking to consolidate, save costs, simplify their environment. And, I see all of this consolidation, happening. Now, whether that happens 2 or 3 years from now or 3 to 5 years from now, or even longer, I don't know. But I think it will start to happen across the healthcare enterprise before it starts to happen within the hospital. But I think this whole convergence to a single platform it will ultimately happen.
And of course, the care not happening in the actual hospital. So solutions that traverse the enterprise and beyond. What the enterprise is different than what we used to think it is.
Yeah, clearly. And I would include all the way to the home as well. Patient engagement vendors have been looking at this broader, and it is a much bigger value proposition than just looking at the hospitals itself.
Thank you, Brian. I'm going to have John take us home. So, John, the nurse call companies have been highly territorial about connecting their infrastructures to third parties, living in fear that control over their workflow and the value of their capabilities will be diminished. And you covered this a little bit earlier. What does the future hold for the software side of platforms like Nurse Call in an EMR-centric universe?
It's an interesting place to go. I had said at the beginning my view of Nirvana, and I suppose it's a view that was shared by many of us in the early days of, I'll say, middleware, to include Michael McNeil, who many of us still look to as the godfather, if you will, from his days at Emergent. Brian worked for Michael. I worked with Michael, and Michael really defined a space. Back in the early days, it was a duopoly here with Connexall in Canada and Emergent in the US. And Connexall later came to the US in 2010 when I formed the company, largely because Emergent had sold to Philips, and Philips had really ceased to market Emergent as a multi-vendor platform favoring enhancement of the Philips platform, which we've seen happen over again. But in any event, the idea that we have an air traffic controller of sorts, and Brian said that convergence where there's a single platform handling all communications, I think that's That's really where we'd like to see the industry get to. When it gets there is anybody's guess. I had a call last week with a particular hospital system, and they're unhappy with their current nurse call vendor. And Kenny, you and I have seen this movie before. But apart from the hardware replacement costs, what they identified as their major impediment to solving what they perceive as a problem is the structured cabling that lives in the walls. And the reason for that structured cabling is all of these systems, in this case, we'll talk about nurse call, we'll stay with nurse call, that structured cabling exists to transmit proprietary digital signaling. And at its core, a nurse call system really lights a light so a nurse in a hallway can see that he or she and their presence is needed, sounds a tone at the nursing station to bring someone's attention to that light, right? Hence the phrase, lights and tones for nurse call systems. And over the years, led in many ways by Rolland, who has been for years and remains the market leader, by bringing more advanced features to their nurse call, making it more proprietary, not less. So in my conversation with this customer, we talked about, wouldn't it be interesting if nurse call deployments were like telephony deployments? When you install a telephony system, maybe you pull 60 pair of low voltage wiring, you punch them down, and if you were to change your phone system, you grab some new pairs and you punch them down, and voila, you're up and running on a new telephone system. That doesn't exist in nurse call today, but if in the future, well, I think there are two ways that nurse call can go. One is it will be supplanted by IP-based patient engagement systems once UL 1069 is breached, if you will. So UL 1069 is a regulation that says you must have this uninterrupted, highly reliable, you might say completely reliable system to sound those tones and light those lights when a patient requires attention. So UL 1069 allows the industry to remain, in my estimation, rooted in the past, in the way that we've always done things. And these smart engineering graduates in Silicon Valley and Austin and Boston and Lord knows around the world aren't so far able to launch new, innovative nurse call systems based on IP, based on tablets instead of pillow speakers, and all those other things that we might imagine for a nurse call system because of the regulations. So if those regulations don't go away, if you will, if they aren't set aside, because lobbying being what it is makes the regulatory, the building licensing authorities hold on to those UL regulations, then we could go backwards and we could have dumber nurse call systems. And we could have simple switches and lights and tones that are controlled by that all-knowing air traffic control system, so that hospitals aren't spending multi-million-dollar capital projects to put in nurse call. Is just something that connects to the air traffic controller at a much lower cost. So we're either going to get more intelligent and less wedded to the standard that guides nurse call today, UL 1069, or we'll hold on to UL 1069 and nurse call systems will get dumber, not smarter, and the air traffic controller will handle not only nurse call, but the other kinds of events that need managing in healthcare.
Yeah, and the three of us have seen this over and over again. So, over the last 10 years for sure, certainly over the last 3 to 5 years, many customers are less willing to let whichever their existing provider is, own the whole thing. That's in the end, a nurse call platform is just not capable enough of being that larger air traffic control. Well, thank you very much, John and Brian. And for those of you watching, I encourage you to hit the like button and subscribe so that you can get notified when we release our next episodes. Make sure you subscribe on your favorite podcasting service or visit us on the web at www.lonestarcom.com/podcast. That's www.lonestarcom.com/podcast. Thanks so much for listening.